All right, good evening, everyone. I'm very excited to have a chance to host this Meningioma webinar on behalf of Stanford Medicine and Neuroscience and Neurosurgery and Dr. Chang. I'm Fred Lamb. I'm a clinical instructor here in neurosurgery, working specifically under Dr. Chang. And we treat a lot of meningioma patients, both open surgically and also with radiosurgery. So I thought today's webinar, I would introduce some of the current technologies that are being used to both diagnose and treat meningiomas that some of these patients that I have who have generously also allowed their cases to be discussed. I will use these cases as a means of introducing what are the current technologies being used to treat these meningiomas, some of the current research that's based on the new 2021 World Health Organization reclassification of meningiomas, and what are some of the clinical trials updates that are ongoing here at Stanford and perhaps elsewhere in the world. But before we get started, it is my distinct privilege to introduce Maureen, who is our Neuroscience Wellness Ambassador, because she has some very, very exciting news for all of us. Maureen, take it away.
Thanks. Hi, I'm Maureen Murphy, and I am a volunteer at Stanford, and one of my roles is as the Neuroscience Wellness Classes Ambassador. This program was formerly known as the Neuroscience Supportive Care Program, and it was rebranded and streamlined in 2024. It's an amazing program. The classes are all evidence-based. They are free and open to the public. You do not need to be a Stanford patient to participate, and they're offered to both patients and their caregivers. We have a range of classes. There are over 25 free weekly classes. Most of the classes are on Zoom. And one of the best benefits of the classes is that it allows patients to connect with others that are having similar life circumstances happening. So we target 3 different areas. The first is the mind-body connection. And those classes that we offer are sound bath, meditation, Tai Chi, Qigong, and yoga. And in preparation for this role, I took some of the classes, and one of them was sound bath healing. And it honestly was a life-changing experience. That is one of the in-person experiences, like in-person classes. I also took the Tai Chi class, and the instructor was amazing. So we also have classes that target fitness with strength training, aerobics. There's a tango class, balance classes, and dance classes. And then there are creative arts classes that 3 creative arts classes. One is improvisational theater. And my supervisor took that. I have not. And she said it was amazing. And ukulele, and then healing strokes, which is actually a class that people create a piece of artwork during the Zoom session and then share with one another at the end. So there are 3 different ways for you to get to participate in this class. One is that your physician can send an Epic order, or you can get your information through in your after visit summary. Or the easiest way to do it, and I am not a technologically savvy person in any way, is you just click on our website and you click on the class you want to go, and a registration will pop up, and you'll get an email confirmation. So I actually don't know if we need the next slide, because I realized that this is a support group. Is that right?
Oh, no, you definitely need the next slide, because I literally think I'm going to subscribe all of this therapy, Maureen.
Okay.
So it was the universe telling me that I need to find some wellness,
Yes.
but the support should not only just be for our patients. I think support should be for the community of physicians and providers and everyone that provides support. So yeah.
I completely agree. Yes, I completely agree. So that we are looking for clinical advisors, and if you are interested in giving us your input about what classes would benefit patients, if you could put your name. I know there's not a chat since it's a webinar. I haven't done a webinar before, so I don't know if there's a way, or if they could send the name somehow to you guys through Q&A, and you could let me know if anyone's.
They can also email me. Or input their name in the Q&A box on the bottom.
Okay, so if you would submit your names, we'll reach out to you. It's just a couple hours commitment each year. We anticipate just through email, and you can even help participate in instructor auditions. And I can we have a digital flyer, so I can send that to you also, that has all the information.
Great.
Yes, so
that's great, Mark.
Yeah, thank you. It's a wonderful program. I hope everybody participates.
Thank you. Well, you're welcome to keep listening to our webinar today and give some feedback as well. And if otherwise, we will get started.
Okay, thank you so much.
We have a patient who has a question.
Oh, the patient has a question. Absolutely.
Let's see here. There you go.
Hello, thank you. Oh,
there you go, Leslie. Hi.
hello, thank you. I'm Leslie. Are these a couple of questions? One is I went into the Q&A to put my information. It said the host had that turned off.
Oh.
And the second thing was, are these online classes?
3 of the classes are in person, but all the rest are online. Yeah, they're virtual. So
And I'm a patient, so I could attend them. That would be great.
Yeah, they're really wonderful classes. Yeah, and the majority are online.
Okay, thank you so much.
Thank you, Leslie. I think we really have to thank the COVID pandemic for really blowing up online virtual wellness classes, because I definitely took more yoga classes online during the pandemic than I do now in real life here. And I think this is also a very great opportunity for us to try this hybrid virtual webinar format. And we really kind of want to bring back the live audience in a post-COVID in the post-COVID era, because I think we're all a little bit being shell-shocked for the last 5 years, and hopefully this will be the start of some hybrid sessions where we will allow more Q&A and in live interaction. And so in the interest of time, let's start with today's webinar. So it's a long title, but I thought we would take the opportunity to update everyone on the current World Health Organization, the WHO classification of meningiomas. And I think this is really important because we're now entering the era of molecular genetics and biomarkers in terms of how we identify these tumors, not only just meningiomas. And at major academic centers, and of course across the world as well, we are now able to take pretty much any type of lesion or tumor that we find in the brain or the spine or elsewhere, and put them through a battery of tests of genetics and testing that gives us a lot more information on how we can then help our patients design more personalized tools for therapy. And around that, we've had the privilege of being able to share some of our patients' cases in this format. So, I want to thank our patients for being so generous to allow us to discuss their cases. I have been very sensitive to de-identify all information, but we will do a case-based discussion on implementing some of these cutting tools to assess tumor recurrence and other types of ways of treating the tumors. And then I will just quickly talk about what's going on in the world of clinical trials for meningiomas, not only here at Stanford, but what's available elsewhere. But let's start with a primer. I'm sure everyone knows what a meningioma is, but let's just start with the basics. So meningiomas are the most common primary extraaxial brain tumor. So what I mean by extraaxial is that the tumor actually meningiomas don't grow within the brain matter itself. They grow from this leathery layer of the brain called the dura mater, which is Latin for hard mother. And meningiomas represent, and therefore they're called extraaxial brain tumors. And they represent 37.6%, about 38% of brain tumors in adults. So it's one of the most common brain tumors that we'll see both in the clinic and in the OR, and in other forms of modalities of treatment that I will also be describing in today's webinar. And they are thought to originate from these little arachnoid cap cells from within the dura mater itself. So it's really quite fascinating how such a thin layer of a leathery layer of lining can grow these big tumors that can cause a lot of issues and problems for patients. 80.3% of these meningiomas are located in the cerebral meninges, and so they grow attached to these meninges. 4.2% of these spinal are located in the spine because the meninges also wraps the entire spinal cord. So you can also have spinal meningiomas. But 14.7% lack a specified meningeal site. And it's really interesting how some of these tumors can also grow elsewhere, not just attached to the brain and spine, but thankfully they're quite rare. So most patients are diagnosed between the ages of 40 to 70 years with a peak age incidence of 65 years old. Women are 2.3 times more likely to have a benign WHO grade 1 meningioma than men. And we can go into some of the biology and the genetics of why that is. Spinal meningiomas account for about 25 to 64% of all primary spine tumors, with, again, a strong female predilection. Okay, between 75 to 90% of cases are in females, and they have a peak incidence of of about 6 decades of life. So the 2021 WHO classification of meningiomas classifies things into 3 categories, and I'm missing the third grade. So benign is mostly what we see, grade 1. Atypical is grade 2, and then the malignant ones are grade 3. Now they're quite rare. That's probably why I purposely didn't even type it in. So they are generally benign, incidentally diagnosed. And what I mean by incidentally diagnosed is oftentimes people will get neuroimaging for some other unrelated reason, and all of a sudden you will find a report that says you have an incidental meningioma. So these are asymptomatic. You don't really know that you have them. And they can present with mass effect. And what I mean by mass effect is that they can grow to a size that they end up putting pressure on the brain, and they can cause one of several symptoms. They can either cause a seizure, and a seizure is a way of the brain telling us that there's something pressing on it, affecting the electric circuitry to hyperactively activate. Or you can have signs of raised intracranial pressure, especially if these meningiomas are in delicate, tight spaces of the brain, like the brainstem and the skull base here. So meningiomas can be associated with genetic syndromes. So, in the neurogenetics department, we also see a lot of NF2 and NF1 patients, von Hippel-Lindau, Gorlin syndrome, and Li-Fraumeni syndrome. So these are all genetic syndromes that can predispose patients to have meningiomas. And now we know in the era of sequencing and whole genome sequencing and genetics that there's several genes that are also mutated, and if they are mutated, they can also increase a patient's risk of having increased sensitivity to radiation or radiation-induced meningiomas. So in terms of when we take a patient's sample from the OR and run them through a battery of molecular panels, a lot of these genes will pop up in terms of identifiable mutations that are known through research to drive mutagenesis and meningiomatosis. The tumor location also correlates with the mutation spectra, which is also very interesting. In the past, so about 10, 15 years ago, before the ability to do more specific biomarker testing, what we would get from a pathology sample is some very, very basic information. And from that basic information, we then guided treatment. And that largely has served us well throughout the course of the past decades. But the ability now to then hone in on specific markers and mutations really helps us then guide the patient as to, hey, what are some of the risks of having a meningioma in a certain area in the brain or the spine that holds a certain type of mutation. So we know that with convexity or spinal meningiomas, and what I mean by convexity meningiomas, these are meningiomas that sit on the top of the brain. Okay, so convexity or spinal meningiomas can have a chromosome 22q deletion or NF2 mutations. So we also, so when we screen our NF2 patients, we usually do a brain and spine hollow imaging to make sure that they don't have other associated lesions outside of their neurofibromatosis. Skull-based meningiomas can harbor mutations in AKT, TRAF7, SMOOTHIN, PIK3CA, and this is also very interesting because we're very fortunate today to be able to present a patient of ours who does harbor a PIK3CA mutation and discuss the case surrounding that. So it's really interesting how we now know that meningiomas that grow in different areas of the brain harbor different types of targetable mutations. And what's exciting about it is knowing these mutations and these genes that are mutated has allowed the pharmaceutical industry and also at the basic science level, drug discovery and targeted therapies that can then target these actionable mutations. And we're really in the era of precision cancer medicine for our patients. And, we're going to use a case in point to discuss this. And the ability to also understand where the location of the meningioma is and whether or not they can be predisposed to drivers of genes that can drive meningiomagenesis in the areas where these meningiomas are also highly informative. Because perhaps, if this a meningioma that grows along the midline sagittal sinus area harbors a SMARCBA mutation, perhaps there's a SMARCA-BA inhibitor that can then be in the future used to then inhibit these meningiomas from growth or recurrence. So, this is really, we're now again, we have to update our understanding and our ability to offer our patients a lot more genetic information. And I think that's really exciting. So the way the 2021 WHO classification has reclassified meningiomas hasn't really changed from the 2016 WHO classification system. We're still grading things as grade 1, grade 2, and grade 3. So any of our patients who have come to see us over the last decades or 2 or 3 or 4, and we've been tracking them longitudinally, you don't have to worry. The grading of the meningioma itself has not changed in terms of whether or not they're benign. So grade 1 meningiomas under the 2021 WHO classification will still be considered benign meningiomas. Recurrence rates are still the same. Grade 2 meningiomas are still considered atypical, and they tend to have more of these high-powered mitoses. So the cells tend to divide a little bit more, which is why they tend to be atypical. They can still undergo brain invasion, and that's some of the imaging characteristics when we look at the way the meningioma sits on the top of the brain or wherever it is. We can still use that older classification to inform the patients that, hey, we know that this is likely going to be atypical, and this is how the course of the treatment and recurrence is going to be. And grade 3 meningiomas, they're rare. They're still considered anaplastic and malignant. Okay, and the main power of then understanding the 2021 addition of genetic markers is these TERT promoter mutations and these homozygous deletions in CDKN2A or CDKN2B. These are these cell cycle regulator genes. And then also outside of that, we have the ability to then screen all these other types of targetable genetics that we now know can also predispose to the formation of different classes of meningiomas. So this is a very extensive table. It's a lot of heavy information. For the audience who wants to know where the source that I got this information from, I'm happy to provide that reference. For the sake of our presentation today, I would like to focus on the PIK3CA kinase gene mutation. That tends to lead to the development of the whole range of either grade 1 to grade 3 meningiomas. The typical location is either in the anterior or middle skull base. And they have a low recurrence risk, and they can be driven by progesterone and cybertonin and anti-androgen therapy. Okay, that shows a higher PIK3A mutation rate in skull-based meningiomas. So this is an interesting gene that is mutated because there is now an actionable inhibitor that can be used to inhibit this gene driver that drives the disease. So I'll discuss that a little bit later. So the main treatment of meningiomas for benign meningiomas is still trying to achieve gross total resection. And what I mean by gross total resection is we will be removing the tumor on bulk. And also, usually we take about 1 centimeter of the dura that is attached to the tumor, because we know that usually, or on imaging, there's usually, you will read your imaging report and you say there's a dural-based enhancement. So we try to take all of that enhancement of the dura around the tumor itself, because we know there's probably creeping meningeal cells there that if we don't clear that margin, the risks of recurrence is higher. And adjuvant radiotherapy is usually reserved for only grade 2 or grade 3 tumors. We tend not to radiate our grade 1 patients if we're able to achieve a gross total resection. And of course, incomplete resection or aggressive histopathologies are associated with recurrence and transformation to a higher grade disease. That can be applied to most cancers in general. So benign meningiomas have a 83.7% 10-year survival, so it's an excellent survival. Malignant ones have a poor outcome, not surprising, 61.7% in 10 years. Recurrences are most common in grade 2, so you have about a 50% chance of recurrence, and grade 3, 90%. So a lot of these numbers now are improved because we are also in the era of being able to treat meningiomas with stereotactic radiosurgery, which I will also talk about later on in the talk. And the ability to combine multimodal therapies, which is now becoming the gold standard of care to treat all types of tumors, has really allowed us to improve and push out survival past some of this older literature before the use of targeted therapies or multimodal combination therapies. So the first case that I will present, we're very lucky to have this patient agree for us to present her case because she's also a well-known member of our meningioma support group family. It's also a rare case to be able to have such longitudinal follow-up. So this is a patient who presented to Dr. Chang's clinic in August of 2010 with a right-sided occipital meningioma. She underwent a right-sided occipital craniotomy for a gross total resection of her meningioma. The histopathology at the time demonstrated a WHO grade 1 meningioma with the absence of increased mitoses, no hypercellularity, no necrosis, no macronuclei. So these are all kind of buzzwords in the way that we read these pathology reports. The absence of these features justifies the classification of a benign tumor. So this was all, a very good prognosis in terms of a gross total resection and then longitudinal follow-up. So this was her pre-op imaging back in August of 2010. You see a very discrete dural-based lesion in the right occipital lobe. You have the lining of the dura right here, and you have the way that it abuts the sagittal sinus, which is this midline structure here, this major venous channel, which is also lined with meninges. So this is a meningioma that touches the sinus but doesn't invade the sinus, which allowed Dr. Chang to do a full gross total resection. So this is the post-op imaging, and it shows the resection cavity. There's no more tumor, obviously. The brain just bounces back and is almost like it was never there. Great results. And then you can also see in the coronal aspect, the entire tumor has been removed. So this is really textbook post-op imaging that we want to achieve for our meningioma patients. She represented to our clinic in 2013 with loosening of the cranial plates, which required a second surgery to remove this hardware. Imaging at the time also showed no evidence of disease recurrence. So this was her July 2013 surveillance imaging prior to removal of the hardware. Again, a very clean scan. There's no evidence of recurrent disease. There's no enhancement of the dura. It's very similar to the 2010 scan. And then she was out there living life and enjoying things. And she presented to our clinic recently in April of 2025 with imaging suggestive of disease recurrence at the site of the craniotomy. The imaging also suggested nodules of meningiomas along the superior sagittal sinus that was in front of the site of the craniotomy. So this is her imaging in April of 2025. You do see that there is a dural enhancement here at the site of the original meningioma. There is a growth outside of, instead of growing into the brain, there is now this enhancing lesion here that was read as being extraosseous. And what I mean by extraosseous is that this is the skull, and the lesion has grown not into the brain, but into the inner table of the skull. And on the coronal, it looks very similar to how it looked in the first presentation, except now it's abutting up, not going down. So the question is this related to the original meningioma, or is that something that is a different entity, a different disease that may have grown within this cavity of the previous surgery? And also here, it wasn't reported in the radiology report, but here you can really appreciate that there's little nodules of meningiomatosis that lines the superior sagittal sinus. And this is this big venous structure here. And why that's interesting is, again, from the previous slide, we now know that location can dictate where these meningiomas can grow. So I'm just going to quickly scale back to my previous slide showing location and genes that could drive meningiomatosis in different parts of the brain. So, we had a long discussion about how we would work up whether or not this was a true recurrence or whether or not this was some other entity that just happened to grow back in the site of the original craniotomy. And so we also referred this patient to our radiation oncology colleagues for the potential of treating this lesion with radiosurgery. And we put all our heads together and we suggested using imaging tools to detect whether this was recurrence that was specific to meningiomas or whether this was uptake of something other than that. So current tools that we can use to test recurrence is nucleotide imaging. 18 dehydroglucose PET CT scan is really good in uptake of any type of hypermetabolic cells. But it's not super specific in terms of being able to say whether or not this is a meningioma or not. There is now another type of nucleotide treatment or diagnosis called dotatate PET CT using a specific tracer, 68 labeled GA. And this is dotatate therapy is a form of a peptide receptor radionucleotide therapy. So this is, again, a very specific targeted type of diagnostic tool that allows this tracer to bind to the somatostatin receptor, and this receptor is highly expressed in the surface of meningiomas. So this is what we call a theragnostic tool. It's a small tool that allows both diagnostics and therapeutics to be used, and it helps differentiate meningioma versus other things. So if this lesion was bright on PET, on FDG PET, this could either be a meningioma or something mimicking a meningioma. If it was hot on the dotatate PET, then it most likely is a meningioma. If it's a cold on dotatate, then it may not be something else. And so that's one of the tools that we can use to help patients differentiate what exactly is growing at the site of an original tumor surgery, or if there's something distant to the site, is that also something that we have to address and potentially monitor and treat? So the dotatate PET is we can observe uptake in all grades of meningiomas. It's highly sensitive, so 98% sensitive and very specific. And it allows also, interestingly, to discern bony involvement that can be often reported in the MRI. So hopefully when this patient gets the dotatate PET, we will be able to help give her some answers as to whether or not this is true recurrence of the meningioma or something else. So this is an example of what the dotatate would look like. It looks like any type of pseudo color heat map scan. So this is a patient that has multiple meningiomas at the skull base, and this is post-surgery. There's some recurrence here. And is this truly active disease? And it lights up on the dotatate. So this is suggestive that this is an active recurrence. So this is one way that we can now offer patients the ability to then see whether or not this lesion needs to be treated, if it's actively bright on dotatate, or is something that is quite indolent and doesn't show any type of activity, and we can still safely do surveillance imaging without any types of other types of downstream treatments like radiation therapy, etc. So that's one way, that's one of the newer tools that is available in most centers that will allow us to use radionuclide therapy to differentiate recurrence versus other things. So case 2, again, very interesting case. This is a patient who presented to our clinic as well, harboring a PIK3C kinase germline mutation. And this germline mutation is part of a syndromic mutation, and she presented with a history of headaches and migraines that had been treated with Botox, but had an MRI brain workup for something else other than this meningioma. But it did reveal that on the MRI she had what was presumed to be a left frontal meningioma that was not previously seen on an MRI in 2014. So over the course of the decade, this meningioma slowly grew to the size that it is in this frontal lobe. So, again, we see a little dural tail here, And you can see how this meningioma sits with little, it almost looks like little fluffiness that has adhered to the surface of the brain here. You do see a little bit of this darker shadow on the MRI, which suggests that there's some underlying edema or swelling of the brain. And, so the interesting thing is whether or not this meningioma is being driven by the PIK3CA kinase mutation in her germline. And interestingly, now we have targeted therapies, an inhibitor called alpelisib for the PIK3CA related overgrowth spectrum, which this patient is currently on. And hopefully this will be able to target this PIK3CA pathway to halt the growth of this meningioma. Meningiomas can also be driven by the PIK3 AKT mTOR pathway and the MEK pathway, and there's now a phase 1 clinical trial in patients with progressive refractory meningiomas that uses both combination of MEK inhibitor, trametinib, and alpelisib to able to use a combination therapy to halt the growth of these refractory meningiomas. So this is, again, an example of why we need to do molecular testing and genetics and upgrade the 2021 WHO grade criteria so that we can then identify these actionable targets to use targeted therapies and precisely treat and hopefully eradicate recurrence and disease. And the ability to then be able to do that also helps us further classify the risks. And so, back to that table that I presented, usually PIK3CA kinase mutations have a low recurrence risk, but it does also then also address, because the majority of these tumors occur in females, progesterone therapies and HRT and all that kind of comes into play as to whether or not patients should be on replacement therapy, if that's also going to help, if that's going to have an adverse effect in terms of driving these mutated meningiomas to grow faster. So super interesting case, and very grateful for that patient to kindly allow us to discuss this case. So the third case that I would like to present is a meningioma presenting as trigeminal neuralgia. So this is also super interesting. This patient presented to our clinic with symptoms of trigeminal neuralgia, pain along the left lower face. An MRI showed a small meningioma in the left cerebellopontine angle touching the trigeminal nerve. Now, I'm not going to go into a large discussion of trigeminal neuralgia, but I would encourage everyone to register for the upcoming Stanford Trigeminal Neuralgia Support Group webinar that is happening next week, June 11th, with Dr. Chang, and we can go into a deeper discussion at that time on how to treat trigeminal neuralgia. But this was a super interesting case, how a patient can have a dual diagnosis, a lesion that causes pressure on the trigeminal nerve, mimicking and presenting as trigeminal neuralgia. So in this MRI of that patient's skull base, so this is the cerebellopontine angle, here's the cerebellum here is the pons, and this is literally the angle that holds some very important real estate. So on the patient's right side here, this is the trigeminal nerve as it enters Meckel's cave. And this trigeminal nerve provides sensation to the top, the middle, and the lower parts of the face. So anything that irritates the nerve or puts pressure on the nerve can cause symptoms of either pain or numbness or issues that can cause the patient to have a lot of neurological symptoms. And we can see here that this meningioma stretches the nerve, displaces the nerve laterally. This is the root entry zone before the nerve enters the pons here. And this is likely part of the reason why she's having meningioma symptoms. Now, the other cause of trigeminal neuralgia that we also treat is a vascular vessel loop that can touch the nerve and cause shocking sensations to the nerve as well. So interestingly, we also were able to see on the MRI a vessel loop here that is touching the nerve as well. So perhaps she's got a couple of things going on that's causing these symptoms. Now, because of location of this lesion and the mild symptoms that she was having, we have decided to be very conservative and continue to monitor her with supportive care and the ability to follow up with imaging. However, if we were to treat this in this location, one way that we can treat it quite effectively now is the use of stereotactic radiosurgery, aka SRS. And what radiosurgery is the use of focused beams of radiation to target tumors in the brain and spine. It allows for delivery of high doses of radiation to the target while sparing normal, healthy tissue. And this has really revolutionized the ability to then treat these smaller lesions or lesions that are difficult corridors of access surgically to still offer patients good outcomes and relief of treatment, a relief of their symptoms. So the two most common machines that are used to deliver stereotactic radiosurgery is the CyberKnife machine here on the left, and this was invented at Stanford. It is a robotic radiosurgery unit where the robotic arm can move in 6 degrees of freedom to deliver beams of radiation, focused radiation to the area that is being treated. And the other system is called the Gamma Knife, which is also a stereotactic radiosurgery system. This uses a different type of radiation source. This is a cobalt-60 source, and this is more a LINAC photon-based radiation source. The main difference between the treatment modality is that the CyberKnife uses a frameless system. So in this situation, the patient has a thermal molded mask that is stretched over their face and is mounted to the frame of the treatment bed. The Gamma Knife is largely a frame-based system. So the patient does have to have a radiolucent frame that is pinned on to their head, although now they also have a stereotactic mask. Either tools are equally effective in terms of treating meningiomas in the brain. The advantage of the CyberKnife is that it can also treat tumors outside of the brain versus the Gamma Knife, which is largely just a tool that is used to treat lesions in the brain. So how this would look like is this is an example of a patient that has a meningioma that goes into the Meckel's cave and the trigeminal nerve here. And in the planning workflow, as a neurosurgeon, we would then contour and identify where the lesion is on a high-resolution MRI. And then in conjunction with our radiation oncology colleagues, we would then be able, and the physicists and the dosimetrists, we would able to very accurately, within sub-millimeter accuracy, deliver beams of radiation specifically to the lesion itself and spare all these very sensitive organs that we do not want the radiation to affect, such as the optic nerve here and other areas of the brain like the hippocampus. So radiosurgery really has a long and successful track of record of being able to treat meningiomas, and specifically these WHO grade 1 meningiomas respond very well to SRS, and it can lead to greater than 90% long-term control. There's longitudinal data coming from the University of Pittsburgh. Now, this is Gamma Knife of 972 patients with a total of 1,045 meningiomas, reporting a 93% control rate in patients with a WHO grade 1 low-grade meningioma who received adjuvant SRS prior to resection, while primary SRS patients without biopsy-confirmed histologically graded tumors also achieved a control rate of 97%. So we can safely now let patients know that even if we don't need to go in and get a biopsy, even if we don't need to go and get all that testing done, SRS can still effectively achieve longer-term control rates in the 98, 97, 98% success, which is something that's very reassuring. Of course, with higher grade tumors, the control rates are proportionately lower, 50% and 70% respectively for higher grade tumors. Some studies do show that a dose-response relationship between WHO grade 2 and WHO grade 3 tumors, depending on the tumor margin dose, if we can deliver something higher in terms of the margining dose, the dose-response relationship also improves. And what is also reassuring is that the study did not endorse any cases of radiation-induced chondrosarcomas or gliomas. So, in the literature, people will always be afraid and say, "Hey, I read that radiating the brain caused brain tumors down the road." With radiosurgery, we do now have longitudinal evidence. Unlike old school radiation therapy that targets everything or a wider base of radiation, radiosurgery within millimeters of accuracy of where we need to treat decreases the incidences of having radiation-induced brain tumors elsewhere down the road. So that's also very reassuring. So in the last few minutes, I want to just highlight one current study that is ongoing and recruiting through Stanford and also through the clinicaltrials.gov website. This is an observational radiation therapy treatment trial in treating patients with newly diagnosed grade 2 meningioma that has been completely removed by surgery. And this is a randomized phase 3 trial to study how well radiation therapy works compared to observation in treating patients with newly diagnosed grade 2. So this is atypical meningiomas that has been completely removed and resected at the time of surgery. And the radiation therapy uses high energy X-rays. So this is, again, more radiosurgery versus radiotherapy to kill the tumor cells and shrink tumors. So for those of you who don't know that this trial is ongoing or haven't been recruited or would like to know whether or not you're eligible for something like this, you're welcome to send a message to this contact number. For other trials that are ongoing, because there's a lot of trials that's going on, and in the interest of time, I won't have enough time to talk about everything. I encourage everyone to go onto the clinicaltrials.gov website to figure out to see what else is going on in the world of clinical trials for meningiomas. And so with that, I will say thank you, and let's open the floor to questions.
Let me go ahead and just stop here the recording.